Hello, I'm Robert Demetrio, MD, board certified urologist, and I'm here to talk about newly diagnosed prostate cancer. I made this video to help patients review their treatment options before they come to the office and have a discussion with me, but it could also serve as a reference later on. On my Well Prep page for prostate cancer, you'll see links to other helpful information about prostate cancer that you can refer to at any time. In front of me is a diagram showing the anatomy that we'll be discussing. This diagram and many others will be in the link that's attached to this video on my Well Prepped page for prostate cancer. After the biopsy, most patients have some degree of bleeding in the urine as well as rectally for at least several days afterward. This is harmless and clears up very quickly. Blood in the semen, however, can take several weeks and sometimes even months, but again is not dangerous. Next, we'll talk about prostate cancer grading and staging. When you come to the office, I'll be showing you a copy of your biopsy report. This is going to show the location of every biopsy that was taken and whether or not there was benign tissue found, cancerous tissue found, or other types of tissues such as high-grade prostate intraepithelial neoplasia, otherwise known as PIN, or atypical proliferation, otherwise known as ASAP. Typically, PIN is nothing to be concerned about unless it's found in high volume and high number of biopsy cores. Atypical proliferation, on the other hand, can be a sign that the cancer was just barely missed with the biopsy needle and that further testing and possibly even another biopsy is going to be required. Prostate cancer grading is the next topic of discussion. This is very important for any malignancy, and with prostate cancer, we typically had been using a system called the Gleason grading system, developed by Dr. Gleason a long time ago. This was a combination of two numbers that, when added together, would give you a Gleason sum or a Gleason score. This Gleason score became a little bit confusing when you put certain combinations of numbers together. So very recently, most urologists and pathologists are now mainly using something called the grade grouping. The grade grouping is a number from 1 to 5. The lower the number, the less aggressive the cancer looks to the pathologist. Grade group 1 cancers are typically slow moving and indolent. Grade group 5 cancers are typically very aggressive. Keep in mind, the grade group and Gleason score are subjective values that are given to us by a pathologist. Pathologists are human beings, and although they are very highly trained and usually very accurate, they are giving us their opinion on how aggressive the cancer will behave based on the appearance of the cells. Most often, I will be talking to you about sending your biopsy specimen out for additional testing called genomic testing. There are many types of genomic tests. Some of them are called Prolaris, Decipher, Artera, GPS, and all of them are designed to look at the genetics in the cancer cells and predict the tumor behavior in a more objective fashion. These tests can take several weeks to come back, and usually after the results are back, we are able to have our final treatment discussion. Waiting several weeks for these reports to come back and to have our final treatment discussion can be very nerve-wracking for a lot of patients, and I totally understand that. Patients who have just received a cancer diagnosis feel like they need to be doing something in order to stop it from spreading. Let me reassure you right now, the vast majority of prostate cancers are not going to spread, if at all, for a long, long time. This gives us time to get all the information we need in order to make a smart treatment decision plan. It is quite common for urologists to delay any definitive treatment for at least 6 weeks after the biopsy. This is because the biopsy itself causes inflammation and changes not only in the prostate but in the tissues surrounding it, and makes any subsequent treatment more difficult and also impacts the healing afterward. During this time, we're then able to compile all the additional testing that we need and make an accurate and agreeable treatment plan for the patient. This also gives the patient time to seek outside opinions if they so wish. Let's talk about prostate cancer staging. Most physicians are going to use a system called the TNM staging system. T stands for tumor, N stands for lymph nodes, M stands for metastases. We have this system in order to more precisely communicate a specific diagnosis for a specific patient amongst all physicians involved in treating that patient. Most patients are going to talk to each other in common parlance, saying they have stage 1, stage 2, stage 4, etc. cancer. Stage 1 typically means that the cancer is confined to the prostate, and stage 4 typically means that it is metastasized to distant sites. Most patients are going to be what we call stage T1C. T1C means that we found the cancer because the patient's PSA level went up above the abnormal range, and the patient ended up having a biopsy to find it. The diagram in front of me shows standard staging for prostate cancer. Stage T1 means the cancer is confined to the prostate. Stage T2 means it is also confined to the prostate but is in larger volume. Stage 3 means that it has spread locally outside the prostate, and stage 4 means it has spread to distant sites. Most patients are going to be diagnosed with organ-confined prostate cancer, which means stage 1 or 2. Most of those patients are going to have grade grouping of 1, 2, or 3. If you are a patient who has a more advanced cancer or a very high grade group of 4 or 5, we are most likely going to order some additional testing to make sure it hasn't spread to other areas. Currently, we have a very accurate PET scan called PSMA PET scan. This test is designed to seek out cells that are expressing the PSA antigen on their surface. It's very accurate at detecting cancer that has metastasized because there is only one cell type that expresses PSA, and those are cells associated with the prostate. Historically, we used to order bone scans and CAT scans in these higher risk patients, but the PSMA PET scan has been found to be much more accurate. Most insurance companies are not going to allow urologists to order the PET scan unless they are in a high risk category, meaning their PSA is very high or their stage is high, or they have very high grade of 4 or 5. We used to order scans on everybody that was diagnosed with prostate cancer back in the day, and what we found out was less than 1% of them were found to have metastases. And because of that, the insurance companies have weighed in and given us very strict criteria on who we're allowed to order the test on. At this point, we are at a fork in the road. If the patient does not have any of the high-risk features that raise their risk of having a metastasis, then we go down a certain avenue. If the patient has high-risk features and they are found to have metastases on these tests, then we're going to go down a very different path. The vast majority of patients are going to go down the first path, which is clinically localized prostate cancer, and all the treatment options that we will pursue are intended to cure the patient of the cancer or to keep a very close eye on it. If you are a patient with low-risk prostate cancer, you may elect to undergo something called active surveillance. Active surveillance doesn't mean we're just going to be ignoring the cancer. It means we're going to be keeping a very close eye on it through a very strict protocol that most of the urologists in the state of Michigan follow. This consists of a PSA test and a rectal exam in the office every 6 months, and then every year alternating either an MRI or another biopsy. And some patients elect to have repetitive MRIs or repetitive biopsies based on their own feeling on these techniques. Some patients hate being in the MRI tube for half an hour, staying still. Some patients would rather do anything than have another prostate biopsy. All of these pieces of information come to us and give us a picture over time what the prostate cancer is doing. If we start to see evidence that the cancer is advancing, progressing, growing, then at that point we need to sit down again and say, are we comfortable with the situation and continue watching it, or is it time to pull the trigger and treat your cancer? This is a very individual decision and something that we'll talk about every 6 months together. Some patients will elect to have their prostate removed. This is a surgery called a radical prostatectomy. Historically, this was done with one large incision from the belly button down to the pubic bone, and the patient was in the hospital for 2 to 3 days. Now, with the advent of robotics, this surgery is now done through 6 very small incisions. The patients stay overnight, and the vast majority of them go home the next day. The recovery is much faster, blood loss is much less, complications are fewer, and most importantly, cancer cure rates are the same. The patients do go home with a catheter, and the reason is because when you remove the prostate, you have the bladder and then you have the urethra now disconnected from each other. The prostate was in between them. When you remove the prostate, you have to bring the bladder down to the urethra and sew them together to recreate continuity of your urinary tract. In order to let that anastomosis heal, we leave a catheter in there for about a week. Patient goes home with the catheter in a bag to let their urine drain into it, and the patient comes back to our office a week after they leave the hospital to have the catheter removed. After the catheter is removed, most patients are going to be leaking urine uncontrollably. That's because the prostate is one of the 2 sphincters that men rely on to hold the urine back and to keep them dry. Now that the prostate is gone, the patient then has to rely on their external sphincter, which is the pelvic floor muscle that you can squeeze to stop urinating voluntarily. That muscle needs to be retrained and strengthened to the point where it can now act alone in keeping the urine back and to prevent you from leaking. This muscle is strengthened with something called Kegel exercises, and these are instructions that we will give you in the office to follow. The vast majority, roughly 90% of patients, are going to get their urine control back after 6 to 8 weeks from their catheter removal. Unfortunately, there's still a 10% chance that the patient will continue to leak urine uncontrollably, sort of like a faucet that's turned on partly, that just drips constantly. This is a situation that can be fixed with another surgery, such as an artificial urinary sphincter or a sling or other types of anti-incontinence surgeries. After urinary incontinence, as one of the main side effects of prostatectomy, the other concern many men have is with their erections. The nerves that cause erections to happen are coursing along the surface of the prostate and heading towards the penis. These nerves are in intimate location with the surface of the prostate, and you can't see them during the surgery, but we know where they live. And so it is possible to cut into the tissue around the nerves and try to push them aside so that they aren't harmed very much during the surgery. Unfortunately, just cutting into the tissue and moving the nerves causes you to damage the nerves even a little by picking up and crushing the tissue. And these so-called nerve-sparing surgeries are very valuable at preserving erectile function after the radical prostatectomy in select patients. Typically, if a patient has more aggressive cancer or high volume cancer, the nerve-sparing surgery is probably not wise because it raises the risk that you'll be leaving cancer behind, and therefore the patient will not be cured by the surgery. This is a very individual decision and needs to be discussed with the patient and the surgeon. As far as the erections go, I like to think of it this way. If your erections are very strong going into the surgery, there's about a 50-60% chance that they will remain that way after the surgery, or you might need to have some additional help with something like Viagra or Cialis. If the erections are already weak leading into the surgery, most likely they are not going to be good erections postoperatively. There are other potential side effects and complications of robotic prostatectomy that are extremely rare, such as injury to the rectum or to the intestine, heavy bleeding requiring a transfusion, infections, or complications related to anesthesia. These complications are all less than 1%, After robotic prostatectomy, the PSA value generally goes to a very, very low number, which we call undetectable. What this means is that in the blood sample, the machine is looking for PSA levels in the sample, and if it can't detect the PSA at a certain level, then it'll give you a reading on the report that says less than something. And typically in our area, the PSA will say something like less than 0.01 or less than 0.1. When we see that value, we call it undetectable, and that's a very good sign. Sometimes after the surgery, the PSA does not go to undetectable. It goes down to some very low number, such as 0.1 or 0.12 or something like that. If that happens, we need to discuss that, because that means there may have been cancer left behind and you may need to have some additional treatment after the surgery. But for the most part, when the PSA goes down to undetectable, we will continue to watch that PSA very closely for the first 3 to 6 months, and then every 6 months for the first 5 years, and then yearly, probably for the rest of your life after that. If we start to see the PSA become detectable, meaning it comes to a number that now the lab can find, such as 0.2 or 0.25, then we start wondering if the cancer is coming back, and we will be ordering some additional testing, such as the PSMA PET scan, to find out where it's coming from. Most patients are going to be cured from the radical prostatectomy. All data taken together show the cure rate for patients who undergo radical prostatectomy is about 85%. I think that's very high for a cancer, and I think that patients who undergo a radical prostatectomy, knowing that they have a very good chance of being cured, can go into that surgery with a lot of confidence, and that when we have the prostate specimen to look at, the pathologist will look at that very closely and look at the margins of the prostate, and they will be able to tell us if there's cancer present at the margins. If there's cancer at the margins, that implies that there was some cancer left behind, but not always. So those patients, again, we need to watch very, very closely and see if they're going to need any additional treatment after the surgery, such as radiation or hormone or chemotherapy. For the first week after surgery, because of the catheter, most patients really are not going to want to do much of anything. After the catheter comes out, we usually recommend another 3 weeks of very light activity, which means nothing more than 10 pounds lifting or any strenuous or vigorous exercise. So a total of 1 month of recovery is very typical for patients who've undergone a robotic prostatectomy. The second type of curative treatment for prostate cancer involves use of radiation. There are 2 major types of radiotherapy for prostate cancer: external beam therapy or brachytherapy. External beam is what most people think of when they think of radiation treatment for a cancer. Patient sits on a treatment table at the radiation treatment facility, and a beam is aimed at their target gland for a certain amount of time, and typically those visits last for about 30 minutes. Patient gets up, goes about their business the rest of the day, comes back the next day and does it again, and then the next day and the next day. Typically it's 5 days a week, and most of the patients are going to have this treatment for about 6 weeks on the average. Brachytherapy, on the other hand, is intended to be a more intense radiation treatment that's treating the cancer from the inside out rather than from the outside in. There's 2 main types of brachytherapy. One of them is with implantable seeds, and the other is with high-dose radiotherapy, or HDR. The difference being the seeds are implanted little radioactive pellets about the size of a grain of rice, are put in surgically with the patient under anesthesia in the operating room, and these little radioactive pellets are put in very strategic locations to make sure the entire prostate has been covered by the radiation treatment. HDR is done usually in 2 separate visits, when the patient comes to the hospital and metallic rods are put through the prostate and high-dose radiation is emanating through those rods to treat the cancer from the inside. So obviously, brachytherapy is something that is less time intensive. There's fewer visits, but it does entail coming to the hospital and many times having some form of anesthesia, whereas external beam radiation is a quick in and out, typically 30-minute visit to the treatment center without any cutting, anesthesia, or surgery, and the patient goes on with their life. But it does take quite a bit longer, like I said, usually about 6 weeks in total. The side effects of radiation therapy, no matter how you receive it, are very well known. I like to summarize it as irritability of the bladder and the bowel. So frequent urination, frequent bowel movements, diarrhea, sometimes leaking of urine, sometimes blood in the urine, and sometimes blood in the stool are all relatively common, but also very short-lived. Once the treatments are over, the majority of those symptoms disappear and the patient goes on with their life. There are, however, late complications of radiation that we need to talk about. The most common side effect of radiation for prostate cancer involves the erections. Radiation causes slow damage to tissues, and so initially patients who have radiation therapy are not going to notice any diminished erections at first, but usually 2 or 3 years later they will then begin to notice that the strength of their erections is starting to diminish, and that is very common. Although the urinary symptoms are short-lived, there can be a urinary complication that happens 5 to 10 years after radiation is finished. This is called hemorrhagic cystitis or radiation cystitis. These patients typically have grossly bloody urine, and many times they form large clots that get trapped in the bladder, and they come to the hospital, and many times we have to put a catheter in to flush the clots out and to clear the bleeding, but sometimes we have to take the patient to the operating room to remove the clots and cauterize any bleeding. What happens is the radiation causes changes in the lining of the bladder, and these blood vessels can become very friable and they can break spontaneously very easily. This is, again, something that happens many, many years after the treatments, but we do see it happen from time to time, and it can be very difficult for these patients going through it. I will say that there is a very good treatment for this if you are one of those unfortunate patients, and this is called hyperbaric oxygen therapy. We put the patient in a pressurized oxygen chamber. Think of it as going inside a submarine kind of, and the high pressure oxygen treats the tissue and helps the tissue to heal and prevents the bleeding from happening any further. There are other things we worry about with radiation that are late consequences. Most notably, these are secondary malignancies such as bladder cancer, colon cancer, rectal cancer, or blood cancers such as lymphoma. These are things that usually will get picked up because of their symptoms or on routine blood work, and need to keep an eye out for those if you've had radiation treatment. For the most part, radiation is very easy to go through up front, and typically there are very few long-term issues from it. The cure rate, unfortunately, is a little bit lower than surgery, and here comes the trade-off. Radiation is usually easier to go through, but the cure rate is about 5% lower. So what we usually say is about 80% of patients are going to be cured with radiation therapy, as opposed to 85 to 90% of patients who undergo surgery. So the trade-off is less invasive, less problems, but lower cure rate and potentially late complications that can cause you trouble later on. Many patients have very strong feelings about their desire to have radiation or surgery. Many of them have had a friend or relative that had their prostate removed or had radiation and either did very, very well and were very happy with their outcomes and were cured and had no issues, or they had a terrible outcome, many side effects, many issues, and that can influence some patients' decisions to undergo one of these two treatments or not. So this is a discussion that we just need to have and explore all of the issues that can arise from them, as well as the upside to each of these treatments and make a good informed decision together. There are other treatments available to patients with prostate cancer that we do not have in our immediate area at the moment. These include high-intensity focused ultrasound, or HIFU for short, cryotherapy, which is freezing the cancer, and electroporation. Some of these treatments are available at other institutions, such as in Detroit, or at other major referral centers, such as the Cleveland Clinic, Mayo Clinic, Memorial Sloan Kettering, etc. High-intensity focused ultrasound is something that may be available to us here in Lansing in the very near future. This uses ultrasound waves that are focused very specifically on areas of cancer to heat that tissue, denature the cells, and cause them to die while leaving the rest of the surrounding tissues undamaged and intact. This will probably be something that's going to be most useful in something called focal therapy. In patients who have low risk, highly localized cancer to one part of their prostate, these focal therapies can be thought of as just treating where the cancer was found, but leaving the rest of the prostate undamaged. This causes less side effects, less problems with erections and urination, but also curates that are as close or near other more invasive treatments. This is an exciting thing that many urologists are looking into at the moment, and stay tuned for that possibility here in our area. There's another form of radiation therapy called proton beam that is not available in our area, but I can refer the patient to a center that's reasonably close by if they wanted to seek an opinion there and find out more about that treatment. So what happens after radiation in terms of tracking the cancer? Unlike with surgery, it's very unlikely that your PSA will come down to an undetectable level on your test results. What we generally see is the PSA come down to a very, very low number, and the lower the number, the better. And typically that number will be somewhere between 0.1 and 0.5. It really doesn't matter what that number is, as long as the number stays stable over the years. If your PSA comes down to 0.6 after radiation therapy, don't be alarmed. We're going to continue to track it closely. If it stays at 0.6 or somewhere around that and doesn't continue to go up repeatedly on subsequent checks, then that is a cure according to oncology criteria. If we see a PSA rise 3 times from its low point after treatment, that's called a radiation failure. And if that happens, we're going to need to perform another biopsy on the prostate and possibly even perform a PSMA PET scan to see if it has spread to other locations. Generally speaking, patients will continue to come in every 6 months for the first 5 years to follow their PSA numbers, and then just like with surgery, we will follow it on a yearly basis for the rest of their life. So if we go back to where we started at that fork in the road between going down one way, which was localized cancer, or going down a very different path, which is treating cancer that has spread outside the gland, we need to talk about other very different treatments. These include hormone therapy and chemotherapy. Hormone therapy is something that over the years has been used quite a bit. And just to be clear, because some patients will say this, that they're getting female hormones. That's not the case currently. What we do is we give the patient a medication that tells their body to stop making testosterone. Testosterone is made, the majority of it is made in the testicles and a small amount in the adrenal gland. Back in the day when I was a resident, we didn't have some of these medications, and we had to do something called castration, which means we had to surgically remove both testicles. And that resulted in very low testosterone levels. But nowadays we do something called chemical castration, which means we don't have to remove the testicles, but we give the patient a medication that prevents the body and the testicles from making testosterone. We give patients these treatments if they are very high risk and they're going into, say, surgery or radiation. This tends to make the treatments have a higher rate of curing the patient, but most of the time it's used in patients who are going down this other side of the fork in the road, who have distant spread of disease or metastatic disease, or cancer that comes back after we tried to cure it in the beginning. So we call that recurrent prostate cancer. Most prostate cancers need testosterone to grow. If you deprive it of testosterone, then the cancer will go to sleep, so to speak. It'll become dormant. It'll shrink. The PSA numbers will go way, way down, sometimes even to undetectable levels, and it'll stay that way for quite a while in most patients. What happens over time is, just like any cancer, prostate cancer cells mutate. Their DNA is unstable, the cells change, and eventually, if the patient lives long enough, their prostate cancer cells will then learn to grow without needing testosterone. This is called castrate-resistant prostate cancer. These patients are on the medications Lupron or Orgovyx. Lupron is an injection that we give to the patients to drop their testosterone levels. Orgovyx is a pill that they take daily that accomplishes the same thing. Patients who are getting one of those two treatments, if they have castrate-resistant cancer, their PSAs will start to rise up steadily. If we see that happening, there is another type of treatment that we can then offer, and this is an exciting development that really has been developed over the last 5 to 10 years. These are medications that can target the small amount of testosterone that's being made in the adrenal glands. And once the cancer is deprived of that, then we can then see a reduction in the PSA, and the cancer again will go to sleep. These are medications like Xtandi and Erleada. There are many others that we don't need to get into, but we can talk about together in the office if we ever have to have that discussion. They're very helpful at getting the cancer back under control after it has become castrate resistant. After that, if the cancer still comes back, even after those two things happen, we get into treatments that are actual chemotherapy. And this is chemotherapy that most people think of going to an oncologist's office, getting an IV started, or having a port put in, and having an infusion of a chemotherapy agent that targets actively dividing cells. And chemotherapy does just that, targets cancer cells, which are typically actively dividing cells, and kills them. Unfortunately, it also attacks other rapidly dividing cells that it doesn't intend to harm, such as red blood cells, white blood cells, and so on. And so chemotherapy is a much more involved, much more serious type of treatment that has many more side effects. And these patients are referred to a medical oncologist if we find them in that situation, and they're going to talk to the oncologist about these options and how to best treat their particular problem. Chemotherapy is never given up front for patients who have clinically localized prostate cancer. For example, we don't give chemotherapy to patients who are going to have a radical prostatectomy, a robotic prostatectomy, or patients who are going to have some form of radiation therapy. We do give hormone treatment for some of those patients, like I said before. These are patients who have their cancer has high risk features, and giving them hormone therapy before the start of their radiation increases the chance that they'll be cured. We typically will give those patients hormone therapy for 1, 2, or even 3 years around the time of their radiation. The side effects of hormone therapy can be pretty significant. Obviously, if we're dropping your testosterone levels down to near zero, that's going to affect your sex drive, your sexual function, your erections, your energy levels, your muscle mass, just to name a few. But the other thing that we are concerned about is cardiovascular health and the risk of heart attack and stroke. And these medications have been shown to slightly increase the risk of having a cardiovascular complication over time. These are patients who are exposed to these treatments for many, many years. The other side effect that we worry about is loss of bone density or osteoporosis. So most patients who are receiving hormone therapy are also going to be on a program of maintaining their bone mineralization with calcium, vitamin D, and possibly with an infusion that can be given in the office to drive calcium into their bones and make their fracture risk much, much less. Something really important to keep in mind about prostate cancer. Over the years, I had a saying that I would say to my prostate cancer patients who were just diagnosed, and we're having this discussion in my office. And what I say is, if someone comes to you and puts a gun to your head and says, pick a cancer, any cancer, but you have to pick one, in that situation, prostate cancer is the one you pick. The vast, vast majority of men are going to live at least another 5 years, most likely 10 years, if they don't even have treatment. So think about that. When patients are diagnosed with pancreatic cancer, ovarian cancer, breast cancer, colon cancer, bladder cancer, those are typically much more aggressive diseases that tend to metastasize quickly and early and cause death within a few years if left unchecked. Prostate cancer almost never does that. And even patients who have widespread metastases typically are going to survive another 5 years. So when I see a patient with newly diagnosed prostate cancer, the first thing I tell them is, don't freak out. Even if we didn't know about this, even if we knew about it and left it untreated, you would live another 5 to 10 years of normal, healthy life. So now that we know it's there, we're going to address it. We're going to have a very detailed plan of attack, and we're going to make sure that you're going to be okay. If you're one of the patients that has problems with urinary incontinence after your treatment, we can address that and we can fix it and get it back under control. If you're one of the patients that has problems with obtaining or maintaining erection after your treatment, we can fix that and make that part of your life much, much better. Most importantly, I want you to be comfortable with the treatment option that we talk about and decide on. You will not offend me if you decide to go to another hospital and get a second opinion or a third opinion. I want you to do that. I usually will ask you to do that because I want you to be comfortable with the situation and with the decisions that you're making. This is a very personal decision, and I want you to be comfortable with that decision. If you need records, anything you need for us to send to another institution, you just have to contact my office, or that institution has to send a records request to my office, and we will send them immediately. If you haven't already, you're going to be getting a QR code that you can scan with your smart device, your camera or tablet, and it'll take you to my Well Prepped page for prostate cancer, as well as many other conditions that I treat. On the prostate cancer page, there are links to the Urology Care Foundation that goes through everything I just said in great detail, in more detail than I can spend in a video. And that's a wonderful reference for you to go back and look at as things move forward. Please take advantage of it. Please come back and look at this video again as many times as you want if you need a reminder about all of the treatment options and side effects for prostate cancer. Thanks for taking the time to view this, and I'll see you soon.